Thank you, everyone, for joining us for another Learning Lunch hosted by Format Approved. My name is Brian Johnson. I'm the Senior Director of Online Education with Format Approved, and I'll be your moderator today. Today's Learning Lunch title is A Simple Solution to Access Legacy EMR. EMR data, I believe. We are joined today by Brad Benson, President and CEO of eFormatics.com. Brad has extensive experience with EMR replacement and data conversions. He's been a guest of the Learning Lunch series before, and we are honored to have his presence here with us again today to share his expertise on this subject. We're also joined by Mike Creel. I'm going to advance to his slide in just a moment. Mike is the Director of Integrations at USMD in Irving, Texas. So what makes this session different for us and especially exciting is that we're going to examine a real-world scenario in detail so we can all gain a better understanding of why data conversion is so critical. So I'll let you look at Mike's slide here, and thank you to both Mike and Brad for joining us today.
Happy to be here, Brian.
Glad to be here.
All right. Well, before I move on, I'm just going to take care of a quick housekeeping note. Remember that you can ask questions of our presenters at any time during today's session by entering them into the chat area. In the second half of the presentation, we'll share those questions with our presenters. If we do happen to run out of time, we'll send those questions on and our presenters can get back to you in writing on those questions. One other thing to remember is, and we've already got a question about the slide deck, we'll send the slide deck out after the session. So someone asked about taking notes. If you just take notes on your own at this point, and then we'll send the slides out to you for review later on, along with the recording of this session. So if you happen to miss the live version, you may be listening to this in a recording right now. All right, let's go ahead and begin our session. So Brad, let's start with you, if you don't mind. Can you describe for us what the common problem is for these organizations that are, acquiring other healthcare organizations? What are they running into in terms of their legacy EMR data?
So I guess really the problem revolves around what are they going to do with that data, with that legacy EMR data. So typically, any of the acquired practices or hospitals, they may be running on several different types of EMRs. And with each acquisition that they make, they have yet another EMR and that legacy data from that EMR that they have to figure out what to do with and how to make that data accessible to the physicians from their current EMR. So looking into, what are the options there, leaving the data up and running, or do you migrate the data over to the new EMR system there? They have to figure out what to do with that data in terms of moving it forward. And many times, moving that data forward is not a simple task. It's a complex task. So it can be time-consuming, and in some cases it can be cost-prohibitive to deal with all these different EMR systems. Also, data integrity is a problem there. Organizations don't, if there is data within the old legacy EMR, maybe if they're not interested in moving forward to the new EMR. They don't want to clutter up the new EMR with maybe bad information or whatever it is in terms of it not being quality data or something that they want to move forward. So they have to figure out what do we do with that data. And then really another problem is that they don't know what all their options are with that data. So they kind of assume, well, we got to move it over into the system. We've got to get everything out. We've got to move it over into the system. But there's actually quite a few options that they have there that they really just need to become educated about in terms of what they can do and what the impact is of each of those various options.
Now, Brad, this may seem like an obvious question, but just to play devil's advocate, I guess, or to understand it better, why do organizations need to do anything at all with this legacy EMR data? Can't they just leave all the data in the old EMR, and then if they need to get to it, they can go look at it, but otherwise, just leave it in the old system?
Yeah, there's a couple of reasons why that's not typically something that you'd want to do. And the first reason is really around cost. So there's several costs associated with keeping these old EMRs up and running. You've got licensing costs of the legacy EMR software. You've got hardware costs to keep that software running on a dedicated server or wherever it's at. And then you have support and maintenance of the particular EMR there. So there may be annual maintenance that you're paying to the EMR vendor and just regular support of the hardware there as well. So, and with state mandates requiring you to maintain and keep that data for 7 to 21 years, that's a long time to be, continuing to pay licensing and maintenance costs on multiple systems. And the more acquisitions that occur, the more, the higher those costs get. And then another reason is around accessibility. So physicians, they want to be able to access that, the data from those legacy systems very easily. But if you've got 4 or 5 different systems that they need to log into, accessing that data becomes very cumbersome, which can be a hindrance, in terms of delivering proper care there. So, so those are really the 2 main reasons that we don't typically recommend that is the cost involved and the accessibility of the data.
Yeah, I mean, clearly that's just not going to work over the long term to leave that stuff in, especially for an organization where you're talking about acquiring various EMRs, it just doesn't make a lot of sense to keep those running.
Exactly.
All right, so as I was saying, what's exciting about this session is that we're going to look at a case study, and that's why Mr. Creel has joined us. So we're going to look at the situation at USMD. Could you describe what you were facing there, Mike, so we can understand the scenario?
Yes, and I believe Brad did a very good introduction into explaining our dilemma. USMD was formed in late 2012 with a merger of 3 large medical groups, Medical Clinics of North Texas, which was mostly a multifamily family practice group, Urology Associates of North Texas, which was a large urology group, and a physician-owned hospital, USMD Hospital. When we merged, we had both had large flagship EMRs. Medical Clinics of North Texas was running NextGen. Urology Associates of North Texas was running Allscripts, and both products were mature and functional and paid the bills, so to speak. There was large discussion for Urology Associates of North Texas to move to NextGen, to the larger group, but the cost was prohibitive to consolidate to one EMR, so the group decided to focus on 2 EMRs, one for large family practice or typical family practice groups, and Urology Associates of North Texas would stay on Allscripts and also entertain other specialties that may join the group. When we started, after the merger, when we started requiring other groups, there were a lot of onesie, twosie family practice clinics and urology clinics that were out in the landscape that wanted to join USMD. They were all on differing platforms, and we, as a group, decided that we did not want to support multiple EMRs, and there's a ton out there. So we looked for our options, which were, of course, data conversion, leaving the doctors on their existing platforms, or a third solution, which was the patient archiver. Out of the groups that we have moved to Archiver, there are actually 4 groups that came from differing platforms. On the slide, we had a group that was on Allscripts Professional, and they converted to Allscripts EHR, which is the Allscripts flagship platform. We had another practice that was on Practice Studio that joined, and it's a family practice group, and we used Archiver, and they joined the NextGen suite of doctors. And we had another practice that was on Practice Fusion. Likewise, they were a family practice, and we moved them to the NextGen platform. As it's listed on the slide, we did have concerns about bringing their data into Allscripts and NextGen on the conversion side, largely because quality of data. The next largest concern was cost.
What were your concerns, if I can ask, about the quality of the data? Can you give us a few examples of areas where that could have been an issue?
Yeah. There are a lot of small practices out there, as I would call them, onesie-twosie doctor practices that really don't have professional IT, that don't have a clear thought process when they go into EMR. And so there's just a lot of bad data into their system. There's very little, there's a lot of room for non-conformity of the way they handle patients. Med lists that aren't verified, things like that, if once you bring it into your EMR, you are really responsible for that quality of data.
So I think we're going to review some of the work that Brad did to help you come up with solutions to this, or potential solutions. But so to just sort of round up, you didn't want to take that data and just import it into your new Allscripts and NextGen systems, because then you've essentially propagated that, that data that's bad data, and then it's yours. You kind of own it at that point. Is that the rationale?
Yes, and there's no real way to tell until you've dove into it what the quality of data is, and once they join your organization.
Right.
So.
All right. Well, let's look at what some of the options were. Brad, can you walk us through what your approach was at USMD to figure out what the different archival solutions could be for them?
Sure. Yeah. So with USMD and with all of our customers, we perform an upfront assessment here. We really want to go over with them what their particular situation is, so that we understand their needs and their concerns. And as Mike mentioned, they were merging with a lot of practices here. They had decided to go with, to stick with 2 EMRs versus the 1. Which meant they would have had to, in terms of a migration option, they would have had to move that data into both of those systems there, which can be costly and can be, a lot of effort on their part as well. So, we looked at that, and we, and also with them voicing concerns over the quality of the data, we did realize pretty quickly, and it's pretty obvious and apparent, I think, that a full data migration is probably not the best solution there. So we came back to them after we finished the assessment process there, looking at the systems that they were looking to migrate, and we came back to them and said, Patient Archive is a really good option for you here. So we talked with them about, what is the different data modules that they were most interested in migrating over, which is listed on the slides here. It was problems, medications, allergies, results, and then their progress notes and their scanned images. So they wanted kind of a standard set of data that they're going to be bringing over for each of those particular legacy systems there to be placed in Patient Archive, and we were able to implement each of those individual systems over the course of about 4 to 6 weeks per system there. So that was our approach there, given the situation that they were in and the needs and scope that they had.
Now, listening to you about the assessment, obviously an important part of it is, evaluating the client's needs and what they're goals are, but I also get the sense from what you said that you looked at the legacy EMRs themselves. Could you tell us more about what's involved in assessing the situation?
Yeah, so yeah, the database review is definitely part of that assessment. So we're determining what our extraction options are going to be out of each of those individual systems there. How easily do we think we can pull that data out? What is the quality of the data that exists within each of those individual systems there? And so the assessment process typically works where it's really just a discovery call with the customer to go over the scope, to talk about their individual situation, and like I said, perform a needs analysis there. And after we get done with that, and after we review the data and review the quality of the data, we're going to take all of our findings there, and we're going to come back and evaluate each of the options that are available. And the main two that we're talking about here today is the migration and the archival. We often end up going with sort of a hybrid of the two there. In sort of worst case scenario where they'd have to leave it up and running if for whatever reason we can't get to the data. Maybe it's a hosted solution where we don't have access to the data and the vendor's not willing to provide it. So we're going to present to the customer, what are all of the options that they have available, what is the pros and cons of each of those options, what's the impact in terms of their costs or their timeline to migrate or archive all of that data. So really at the end of the day, at the end of the assessment there, the customer's going to have a statement of work that's going to outline what the cost is going to be, the associated costs with each of those options. And they're going to be fully aware of what those options are and the pros and cons of each. And as I kind of mentioned at the beginning, that's one of the problems is that as highly acquisitive healthcare organizations encounter this problem, they don't really know what all of their options are. So that's one thing that we try to do is educate these organizations in terms of what their options are.
Well, that sort of leads into the next question I was going to ask, which is, I know that in other conversations we've had, you've talked about organizations that will look at each patient chart and sort of convert it into a PDF and then either migrate that into the EMR somehow or archive it. Is that something that's a consideration? Was that in the consideration for USMD? Or what can you tell us about the advantages and disadvantages of archiving the data that way?
Yeah, and that's something that we had seen quite a bit. A lot of the EMRs that are out there have the ability to sort of export an entire patient chart into a PDF. So sort of the thought process was we can get the whole chart out into a PDF. Let's just move it over. Move that document over from there. The problem that you run into with that, or there's a couple of problems with that, is that a lot of times you'll end up with these huge documents that are not very easy to navigate. And what's important as the physicians are looking at the legacy data is that they can quickly find that the information that they need. And if you've got a 200-page document that they're having to scroll through to find that information, it's not really meeting their requirement there of ease of access to it. So, and then another downside to going the PDF route there is you can no longer report on any of that data. Your data, which was discrete in your legacy system, and for those on the call who don't know what that means, it really just means queryable data, data that's sitting in tables there. So, you put that all into a PDF and migrate it over. Now you can no longer query that data for reporting purposes. And as business intelligence and predictive analytics becomes more and more important and critical within healthcare, you're putting yourself at risk of not being able to, look for trends within your data or tell stories about your data going forward. So those are a couple of big, I guess the two main reasons why it's something that we typically don't advocate, and it's something that was not really a consideration at USMD because of that.
It almost sounds to me it's as if you're taking the chart and you're taking a photograph of it, and then you've got this photo of a chart which isn't really useful or comparable to what you've got in a living structured EMR.
Exactly. That's a great analogy. Yep.
Oh, did you want to add something, Mike?
Yeah, I would say that chart to PDF is definitely a tool, and it's a very good tool for medical records, for like distributing to referring doctors and to the patients when they come and ask for a chart. But it's not functional in a true doctor practice where the doctor actually needs access to the data.
I like that word, functional. I think that really captures it nicely. Now, I was just going to ask you as a follow-up, Brad, and I want to mention that we've got some questions from our audience. I just want to remind folks that we will get to those questions here after we've gone through the main presentation, so just hold on those for the moment. I wanted to ask you, Brad, we heard from Mike why they were skeptical about doing a full discrete conversion of that data. Mm-hmm. What made you come to the conclusion that that was not the way to go?
I mean, in their situation, it wasn't about the systems that they were using or difficulty in getting to the data. It was really about the situation, and it was really about their what were the two big things that were their criteria in terms of what are we going to do with this data, and that was, as Mike mentioned, it was the cost there, and then it was the quality. And we realized that having to migrate that data into two systems was just going to be too cost prohibitive for them. So yeah, it was really about the situation. It wasn't about the complexity or the difficulty in doing it. It was just kind of made sense for them for that situation.
Well, we've talked a little bit about the source data that we were dealing with in this situation. I wanted to ask you one more question before we move on, Brad. I've got a couple questions for Mike too, but does it make much difference? So you're dealing with Allscripts Professional, Practice Studio, Practice Fusion. Does the system that they're starting with make much of an impact on how you're going to migrate or archive that data?
It can, and as I mentioned there, it can be all the different EMRs you're dealing with. They're all different. You've got some that are client hosted. You have other ones that are vendor hosted. You've got proprietary database systems versus ones that have a sort of a standard SQL server or Oracle backend. So, in terms of the individual EMRs, now we've worked with many of the EMRs that are out there, but for each of those, what we're really looking for is how easily can we get the data out of that particular legacy system, and try to get an understanding of what the cost or effort is going to be to pull that data out while making sure that we're able to maintain data quality, data integrity, et cetera. So from there, and based on the complexity of getting that data out there, then we're going to make a recommendation in terms of the best fit solution for the customer. So in a nutshell, yeah, it can make a difference, but I mean, typically, data, there is a way to get data out of each of these systems. It just may be the level of difficulty that you may have to deal with each of the individual ones.
Okay. Well, Mike, I wanted to ask you, we've got this list of the data that you were able to migrate, and I wanted to ask, what was the process for figuring out which data elements you needed to archive from those legacy EMRs? How did you figure that out?
It's mostly from what the physicians want the most, but really the bottom line is the most we can get out of the system is what we want. And typically, from what we've seen in our implementations, problems, medications, allergies, results, and progress notes and scan items are it. So.
So it's really the clinicians who guide that determination.
Yes, and in a nutshell, if you look at the list here on the slide, that is the standard suite that that if you were considering doing a archival solution, that this is what you'd be going for.
Okay. Now, I'm curious how much involvement was required from staff at USMD to accomplish this. I could see this gobbling up hours, depending on how it was done. What was your experience with that?
Actually, it wasn't time-consuming for USMD at all. Our largest issues were, number one, gaining access to the legacy EMR that we were trying to convert our archive, and getting system access, database access, and getting the folks and Brad's group involved into getting into the data and doing the assessment. Once they could do the assessment, they were able to say, we can do X, Y, and Z, and then wrote up a scope of work, quoted it out, and then we moved on and got to it.
So you didn't need to commit a lot of staff resources to do this, is what you're saying?
No.
Okay. On the implementation time, that 4 to 6 weeks seems really fast to me compared to things I've heard out there. We follow a lot of EHR news, and I've heard and read a lot about data conversions, that'll take months and people don't plan ahead enough. Was that part of the appeal for this approach, Mike?
Definitely. When our doctors were joining our group, and I don't know how many, most folks out there have dealt with physicians, they'll spend weeks and weeks and weeks deciding on what color paperclip to use. But once they made the decision, they want it done now. In the data conversion or a doctor joining USMD, it takes a lot of negotiation between the doctor and the group to finally get to the doctor to the signing line, and then once the doctor signed and the timeline set for him to join our group, we have to meet that.
So timeliness is critical.
Yes. Now, if, for instance, if we weren't able to get all the data converted, of course their existing legacy EMR still available to them, and then the staff has to go through that standard process of scanning the last 2 or 3 progress notes into the new system so it's available for the doctor, that kind of stuff. And so not being ready at go-live time is not a disaster, but it is a strain on the staff to be able to add not only the pains of working in a new EMR, but all the extra workload of bringing scanned items into the system and ready for the doctor when they see the patients.
Sure, for all the reasons that we've discussed, that's cumbersome. All right, let's move on then. Let's talk about the results a little bit, and I think Mike is probably the best person to address this to start. Could you highlight some of the results you were able to achieve by going with this archive solution?
Well, am I the only one with the screech?
I think we've got good sound quality here. Maybe
Okay.
it was just a passing thing.
Hope so. I had a huge screech on my headset. Anyway, the best thing about our archive solution is it's housed on one server. It is all the existing data that came from the legacy systems came into the archive solution, and we have the ability to make decisions on what people see, which data. So for all scripts, urology doctors, we could just say only that they can see only one set of data or not. In our case, that we've opened it up to all the data to all the practice, so everybody can see the whole suite of data for whatever patients happen to be in that archive solution. It is typically a one-click solution, So let's say if a doctor is working in his practice and he isn't working in Allscripts, and he needs access to his patient data on the archiver. If he's inside the chart in Allscripts, all he has is to make one click inside of Allscripts, and he launches the archiver, launches him into that patient's archive data, and in that spot he has the ability to click through allergies, problems, medications, images, whatever he happens to want to look at. So
part of the appeal is obviously the convenience of it, that it's very easy for the user.
Definitely. Yes. I would say that this solution was a home run all the way around.
Well, can you tell us, was there any resistance within the organization to doing an archive conversion? Because I think this cuts to the heart of it for a lot of folks. I think there's this expectation that isn't very realistic that you'll just be able to kind of hook a wire between the EMRs and the data will just flow into the new one and everything will be perfect. So I wonder if there was kind of an expectation game there as well, or whether you had any pushback on doing it this way.
We had no real pushback. The practices that joined, we told them that they would have access from the Allscripts to their legacy data, and that satisfied them.
So what kind of cost savings then came out of doing it this way? Because we've talked from the beginning about how it can be very expensive to maintain these legacy systems. What were you able to achieve in that front?
Dollars and cents, I don't have anything exact, but I would say that the cost to implement Archiver was probably a half or less of doing a full data conversion. The Archiver allowed us to not have to rely on the legacy EMR, so the importance of those systems being up and maintainable quickly went away. It was just truly a huge cost savings to the entire group.
All right. Well, Brad, if I can ask you a couple of questions. Mike was just telling us about being able to get into that data with a single click from either of their current EMRs. Can you describe how that works? I mean, how do the patients get linked between the archive, the legacy systems, and the current EMR? Brad?
Sorry, was muted there as the...
that happens on these webinars.
Yeah, that's a great question, and we get that question a lot. So I guess that, as Mike mentioned, what that single click access is really just a link within their EMR. It's just a button or whatever that they can click as they're on a patient. Let's say they're on patient Susie Smith or whatever. And it does. It launches. It calls out. It opens up Patient Archive with that single click. Opens up that exact patient. Opens up within Patient Archive. We've got a longitudinal timeline view where they can actually see all of that patient's legacy data within a single screen there. So it's very nice in terms of being able to easily pull up and get a nice visualization of that patient's entire legacy historical record there. But the linking of that there, basically what we're doing there is we're going to be, we take the data, the patient demographic information out of the legacy EMR databases, and then we match that up with what they have in their current EMR system. So we're going to make a link there between any patients that match based on, name, date of birth, gender, social, etc. And then anybody that does not exist in their current EMR system that was part of those legacy systems, we'll send that, we'll create that record either within their PM system, which will flow into their EMR, or directly within their EMR. Now, typically we're not able to get match every single patient up there, so there's some patients that the client will typically have to manually work. And then once we get that mapping back from the client, we create a patient crosswalk between the legacy system and the current EMR within Patient Archive. So that's kind of how that works in terms of the patient mapping there. And it's what allows the physicians to do that single-click access where they don't have to research for that patient within Patient Archive.
I would also like to mention that with the archive solution comes a demographic conversion into our practice management systems. So the demographic conversion is definitely something that the practice will be doing anyway, and the archiver solution meshes up tightly with it.
Well, that raises an interesting question that I hadn't really thought about before. Maybe this is a question for Brad. We've talked a lot about the EMR archive, but what about other electronic systems apart from the EMR? Are there areas where people might need to archive that data as well?
Yeah, there definitely are. You know, and I guess in this webinar we've primarily been talking about archiving really just from an EMR perspective, so taking that data from your EMR. But you know, at least in the case of our product, Patient Archive, it can really house any and all data from any electronic system. So, you know, a lot of our customers are wanting to archive their financial information, their lab, their financial systems, their lab systems, their pharmacy systems, et cetera, in the archive as well, so that they can have easy access to those systems, and then they can retire those systems. And that's one of the additional beauties of an archive solution. You don't have to try to fit all this data from all these disparate systems into an EMR system that may be significantly different and in some cases not be very compatible with the data within your legacy systems there.
So we've talked a lot about the benefits of the solution that was implemented here, but it occurs to me that every solution has some pros and some cons. Was there any downside to doing it this way?
Doing it via an archive?
Yeah.
Yeah, I guess that, you know, there's a couple of downsides that you definitely need to consider. You know, one is that you won't get the full EMR functionality on your legacy data. So something like drug interaction checking or allergy reminders, obviously very important functionality. So in some cases, you know, we would do a hybrid where a big portion of your data would come over into the archive, but anything that requires sort of that or has that functionality within the EMR that requires the data to be there, we can bring that data over over discreetly there. So, you know, and it also depends, like as Mike said, there was quality issues with that data that they had. So even looking at a hybrid solution is not going to make sense if you have real concerns over the quality of the data. So I guess another downside is that it's not, the data that you have within the archive isn't automatically going to be incorporated into the reporting that you may have created out of your existing EMR, as Mike mentioned, Allscripts and NextGen. However, if the organization is using a data warehouse for reporting, for example, you can overcome that downside by taking the data within your archive and moving it into your data warehouse solution. So those are kind of the two main downsides that I'd mention. And it's just something to think about, and it's not that either of those can't be overcome, but it's something to think about in terms of developing your final strategy.
Well, and it comes back to the point of, you know, every situation and every situation faced by different organizations is going to be different. So I guess it must go back to the assessment process as well, you know.
Exactly. Yep.
Well, we've got questions from our audience, and I'm glad that we've got time to share those with our presenters. Before we do that, I want to ask one more question for Brad because, you know, I follow EHR closely, as I'm sure many of our listeners do, and this has been kind of an adventurous year. It seems like a lot of the EHRs are behind on certification because the interoperability requirements are so strict now. And so I just wanted to ask if that situation I talked about before, that fantasy that people have where they can just hook up a wire and everything will move on over into the new system, is that something that's ever going to be the case? And then we won't need archive data? Or what do you see the future holding for that?
Sure. I mean, it's definitely something that's great for everyone. You know, the more progress that's made there in terms of interoperability, the better it is for everyone involved here. But I don't see it as a reality that it's going to be all-inclusive, completely comprehensive. I mean, you know, putting standards in place in terms of how the format of data exchange between these EMRs, with CCDs and standardized coding systems, it's definitely going to make it easier to move limited data sets back and forth. You know, your problems, meds, allergies, and maybe a handful of fields out of each of those individual data modules there. But the reality is there's a lot of discrepancies between various EMR systems. And, you know, there's a lot of fields that are need to be accounted for there. And that's really where an archive solution fills the gap. You know, folks want to make sure, physicians want to make sure that they are retaining everything from their old EMR system that's important to them, you know, and they may not be able to get that done via CCD method here. So, you know, I don't ever see an archive going away. You know, I still see it always filling that gap of either the you know, the particular fields that they maybe weren't able to move via a CCD, or particular data modules that they're not able to, or data elements that they're not able to move via the CCD. They've got an easy place to move that information and store it within an archive. So I really see it as used in conjunction. You know, any progress we make in terms of interoperability, we definitely want to be able to, you know, have our customers leverage. But we see the patient archive as really part of the overall solution and overall conversion strategy.
Well, and you know, beyond that, obviously there's going to be many EHRs out there for a long time that don't have 2014 certification. So this is going to be something people are going to be dealing with for years, apart from any improvements in interoperability.
Sure. Yeah. Yep. That's true.
And we are talking about legacy systems that may not be alive next year.
Right. So there's probably going to be a lot of EMRs that are not going to be supported anymore because they didn't certify for 2014, and they're just kind of going the way of the dodo, I suppose you could say.
Something like that.
Yeah.
Yep.
Well, as I said, we've got a lot of questions from our audience, so let's go ahead and get to those. Again, if we do run out of time, we'll send all of these on to our presenters so they can follow up with you. They can also, if some of the questions require more technical responses, we certainly always invite them to send written responses. Okay, so here's our first question, and it's what regulations or standards do you have to comply with in implementing these projects?
I guess, you know, in terms of the, obviously obviously there's HIPAA. So, you know, typically when we do these migration projects, you know, we try not to take that data outside of the four walls of the organization. So, you know, we want to make sure that everything is secure, that the data remains within the network of the customer there, and that we're not pulling that information out and making it, you know, accessible to the outside world in any way. So that's really the primary, you know, regulation that we deal with. Mike, I don't know if you had anything to add to that, but that's the main concern and that we have, is ensuring that the data remains secure.
Yeah, that's definitely a good question. when the doctor joins USMD, his data is now our data. Us maintaining it to its best form is our goal at reasonable cost, etc.
So a good question here from another member of the audience about working with EHR vendors. I'll just read the question to you. Do you experience problems getting EHR vendors or hosting facilities to agree or support the conversion project when the data for the systems you're converting are actually hosted out in the so-called cloud? That's probably a question for Brad.
Yeah, not really. Typically they're willing to work with us or the the healthcare organization, in terms of providing some level of assistance there with providing them with the data that they need. I mean, you may have some vendors out there that are, they're obviously upset that the customer's leaving, et cetera there, but our experience is typically the vendors are willing to, provide a dump of the data, which they should, and so it's typically something that we want to make sure we address as part of the assessment, that we're going to be able to get that information from the vendor, but the majority of the time it's not an issue.
And as a reminder, it's not the vendor's data, it's the physician's data.
That's a great point. And in a sense, it's the patient's data. So, I mean,
exactly.
It's not something they can legally hold on to. So let me ask a question here that I think is a good kind of nuts and bolts question from the audience. And that is, how do you validate that and maybe this doesn't really apply to the archive, but if you were doing a data migration, how do you validate that data? However you want to address that, Brad.
In terms of the migration or the archive there?
Well, obviously those are different things. They said migration, but however if you want to address both or one or the other, whatever.
Sure, and that's the validation there is, I mean, it's part of the it's part of the testing process that we do. So we have different levels of validation as we're migrating the data through, ensuring that everything has a match within, a matched value within the target system there. So if you're dealing with all the coding systems, making sure that cancer has the appropriate target entry or dictionary value on the other side there. So we're making sure that everything has a match there and reports are produced along the way. And as we go throughout our testing and do our testing of the migration there, we're making sure that, as we're looking at the patients that are in our test set of patients there, that everything is coming over appropriately into the target system there. And we actually involve the physicians at certain points in the process because they're the ones who are going to be using it and looking at the data. So we're saying, is the data that you're seeing in the source system here, is it showing up appropriately in the target system as you want to see it? And then there's certain things that we do in terms of querying the data to make sure that the counts are appropriate and that everything has been migrated over successfully, et cetera there. So I guess the simple answer is there's many points of validation that we do throughout the process.
So here is a question that I think is great because it really speaks to the situation they had at USMD. And the question is, are you limited to local, LAN or WAN environments? Or is this itself sort of a cloud-based solution? How does that part of it work?
So we offer patient archive either way. So it can be, it can be something that the client decides to host within their own network there. And we also offer it as a cloud-based solution. We use Microsoft Azure to host all of that information. And from the end user's perspective, obviously it's no different. They don't know whether it's coming, the data is being pulled from the cloud or whether it's being rendered directly within their network there. So yeah, there's no limitation there. It's not one way or the other. We definitely allow our customers to do either.
Well, and I would think that with USMD, they would need a cloud-based solution because they've got facilities spread out in so many different places.
Actually, we don't have any of our EMR in the cloud as of yet. We have we host our servers in a data center, and it's a very traditional setup.
Okay.
But whether it was, let's say, Archiver was hosted in the cloud or not, if the physician has access to EMR, he has access to Archiver.
Okay. Well,
a lot of our customers. Oh, go ahead.
I think you were going to say what I was just going to say is that, well, maybe it doesn't apply to USMD, but there's got to be lots of organizations that would need that type of cloud-based solution.
Yeah, and it depends upon the situation. A lot of definitely the smaller organizations who don't have the IT staff to support that server or want to support that server, prefer to go with a cloud-based solution.
Sure.
But oftentimes a lot of the larger organizations who sort of do have the folks and the resources to be able to support that, they'll oftentimes go with a client hosted solution.
Now here's a question. Oh, did you want to add something, Mike? I'm sorry.
Yeah, I'd just like to comment that our Archiver system is a single server system.
Mm-hmm.
It has currently 4 physician practices archived on it, and it has tons of space to handle more as needed when warranted, and it's very simple. It's a pretty much from the end user perspective, it's a read-only system. So
here's a question that's very basic, and I certainly don't mean that. It's a good question because we talked about this term a lot and not really defined it. Can we just talk about when we're saying legacy EMR, that doesn't necessarily mean like, a shipwreck out in the ocean. In this case, we're talking about an EMR that you no longer are actively using. Is that a fair definition?
Yeah, it is. It's something that was, as Mike talked about, these practices that they're merging with, and they want to move all the data over to their current EMR. Well, that old legacy EMR is current up until the point of the transition, right?
Mm-hmm.
So that's really what we're talking about. Is yes, they have transitioned over to using Allscripts or NextGen in the case of USMD, and their old system, they're no longer logging into that and documenting within that particular system.
So here's a question that I don't know what it means, so I'm just going to take a risk and throw it out there. Have you worked with CPSI data?
I don't recall. I believe that's a particular. I believe what they're talking about there is that's a particular inpatient EMR.
Okay.
I would have to go back and look. I don't recall working with that, but we've worked with a lot of different systems, so I'd have to take a look. And if you'd like to, whoever asked the question would like to send me an email, we can follow up and get you some confirmation on that.
Well, we'll send that question on to you with the audience member's email address and let you follow up in writing on that one, Brad.
Okay. Sounds good.
We're almost out of time, but I'd like to get to just maybe one more question, maybe 2 if we have time. So here's a great question about cost. Is this an affordable option for a one-doc practice that's currently using a major vendor but wishing to cut expenses and move to a less expensive option?
Yeah, so we have, and the way our pricing works, we have options there for the one-doc shops in terms of what we'll be able to provide in terms of patient archive there. So the short answer to that is yes. We do have affordable solutions for one-doc shops as well as 500 plus physician organizations. So it is something that we recognize there's a need out there for one-doc shops to be able to do this as well, and so yes, we are able to accommodate that.
Well, and in many ways, I think the one-doc practices they need help more than anyone else in many cases, just because it's they have such limited resources that any assistance they can get in navigating this complicated HIT world it seems that they are happy to get any help they can get.
Exactly. Yep. And that's something we realize as well.
It's tough out there for the one-doc shops.
Yes. Very. Yep.
All right. Well, we didn't get to quite all of our questions. We got to most of them. I want to remind our audience that we're going to take all those questions and send them on to Brad and Mike, and so they can follow up with you, especially if we didn't get to the question. I'm sure they'll be happy to answer those individually. I want to thank Mike and Brad for joining us today. Really informative, really practical discussion of what's involved in doing one of these conversions. So thank you so much for joining us.
Thanks for having us, Brian. It's been fun.
Yeah, likewise.
And as I said, there's going to be follow-up after today's session, but if you would like to learn more about data conversion and other services offered by Health eFormatics, visit the URL on your screen there, www.healtheformatics.com. That's an E in there. And when you get the slides after this session, you can click on that link and go right to it if you'd like more information, if you might be facing a data conversion situation yourself. I'd like to thank all of our attendees for joining us today. Remember that we're going to send out a follow-up email that's going to have the slides that you've seen today, along with the video recording of this event. So we've had a couple of people ask about that. Not to worry, you're going to get all of those materials in the follow-up email. Do you need training in HIPAA Meaningful Use, PQRS, or EHR project management? If so, remember that you can always visit Format Approved. Our training store is formattraining.com to see our catalog of online certification courses. You can also visit Format Approved to learn more about our upcoming Learning Lunches. The Learning Lunch button on the home page, it looks like that mailbox you see on your screen there. That'll take you to all of our upcoming webinars where you can learn more and register. Our next Learning Lunch will air July 15th and has the title, How to Maintain HIPAA Compliance on Cloud Services and Mobile Devices. Keep an eye on your email box on our homepage for other upcoming topics. Again, if you are facing a data conversion situation, do feel free to visit healtheformatics.com. I'm sure that Brad would be happy to discuss options with you. Thank you again for joining us today, and we hope you'll join us for our future Learning Lunch events.